The Falls and Fragility Fracture Audit Program comprises of three audits covering different aspects of fragility fracture and inpatient falls care. The National Hip Fracture Database audits hip fracture care across the country. It is the longest running audit program and has got a 100% participation rate. The Fracture Liaison Service Database, the second one, audits all other fragility fractures. It is celebrating its 10th year this year. The third audit is the National Audit on Inpatient Falls. It started off as an audit monitoring inpatient falls that led to hip fractures. Acute mental health trusts, community and other specialist trusts, as well as health boards participate in this audit. Of late, it has expanded to include all fractures and eligible head and spinal injuries from inpatient falls. People are living longer, and with this incredible milestone, it's only natural to see the incidence of falls and fractures increasing. This shifting reality is exactly what we are seeing in the numbers reflected in our audit every year. But despite this year on year increase in demand, the data we have shows that we are rising up to the challenge. We are consistently improving the care we provide to our patients, and it is clear to see in the steady progress of our key care indices and crucially in our falling mortality rates. This is a testament to the hard work happening on the ground every day. But we are not stopping here. While we celebrate how far we have come, we know that there is still more work to be done to push the quality of care even higher. Bone density and strength sees a gradual decline beyond the age of 35. This decline is more pronounced in women in the peri and postmenopausal age group. For many of us, having low bone density can increase our risk of breaking a bone, but it doesn't necessarily mean that you're going to. Herein lies the important message of prevention. Healthy lifestyle is important for bone health, and this can be targeted in many ways. The NHS, the Royal Osteoporosis Society, and various other such organizations provide us advice on how to prevent these fractures. A group of people with some long term conditions are prone to develop these fractures as a result of the illness too. Osteoporosis affects about 3.5 million people in the UK and causes over 500,000 fractures annually. At individual level, fragility fractures can have a drastic effect on well being, pain, mobility, and the ability to continue with a meaningful economic activity, housing conditions, and the quality of life are all affected. Depression is not uncommon. Hip fractures, in addition, carry a 4% mortality rate, and less than half of those recover to pre injury levels. The impact on health economics needs to be considered too. Direct medical costs have a huge impact on healthcare costs of the nation. With reduction in economic activity, the strain on healthcare budgets is there for all to see. However, preventive measures, if effectively undertaken, can reduce the rate of fractures these patients will have, and they will not have to put up with the suffering. Primary prevention is where measures are put into place before the fracture occurs. Secondary prevention is where treatment is instituted when the fracture has occurred. Both these approaches need to be embedded in a systematic manner across all care boundaries. This is what we are all working towards. The Falls and Fragility Fracture Audit Program is the largest database for all fragility fractures in the world. The National Hip Fracture Database has a 100% participation rate and captures all hip fractures across England and Wales. We have over a million hip fracture records. In fact, the National Hip Fracture Database is more complete than the hospital episode statistics, and therefore organizations such as GIRFT Get It Right First Time use the NHFD database to assess trauma units and centers. The Fracture Liaison Service database hasn't reached the levels of the NHFD yet. We have over 700,000 fracture data on the database, and 88 fracture liaison services report to this. Together, they capture about 41% of all fragility fractures in England and about 47% in Wales. On the other hand, the National Audit on Inpatient Falls has a high participation rate of about 96%, and this includes acute, mental health, community, and specialist trusts, as well as health boards. We support better outcomes for patients in three ways: benchmarking, supporting quality improvements, and through research. The database is a rich source of information on how trusts and fracture units perform. Using live data on the three databases helps trusts and units to review their performance along the key care process points. They're able to make changes as needed. They can also compare themselves with previous year's performance, as well as compare themselves with their peers. All this is very useful when reviewing mortality rates, domains of patient safety, surgical, and secondary prevention indicators. The audit program leads are also able to review poor performing trends through live reporting and identify outliers before the performance dips significantly. They're able to support them to make the necessary changes in a timely manner. The database provides insight into workload and demand. For example, the FLS database uses the rule of 5 to predict fracture caseload within a fracture liaison service. The number of hip fractures multiplied by 5 gives the predicted number of annual non hip fractures that the service will encounter. This was born out of research. These calculations, which are embedded in the database dashboard, helps units to consider workforce needs, plan expansion of their services, and streamline service delivery. The Falls and Fragility Fracture Audit Program also provides support for quality improvement to all units across all the audits. Webinars, improvement repositories, live new user sessions, and fracture liaison check ins are very popular amongst the teams. We have over 1,200 attendees over the last year for all these. The Falls and Fragility Audit Program provides quality improvement support to all units across all the audits. Webinars, improvement repositories, and live new user sessions, as well as one to one FLS check ins, are very well attended. We had over 1,000 attendees last year, and many more access these resources on demand. Improvement resources, which are essentially case studies, saw a very high rate of web visits, 3,200 so far. We also provide quality improvement workbooks that take teams through a well structured quality improvement program. The Falls and Fragility Audit Program also has an active program for research. Partner organizations, research units, and individual researchers have made use of the existing data to provide 19 research publications in the last 5 years. We have recently constituted a scientific advisory group to further the research opportunities using our data nationally and internationally. Crucial to all the work that we do is the guidance we receive from our patients and care panel members, who are an integral part of all our audits. Their advice and scrutiny goes a long way in focusing our efforts to improve the quality of care for them. It has been a pleasure to share the work of the Falls and Fragility Fracture Audit Program with all of you. Thank you for your continuing support.